Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about coughing, why we cough, why we feel breathless, and I've got Grog with me to help us out. So, without further ado, let's do it. Grog, why do we cough?
All right, let's jump into it. Coughing is your body's reflex to clear your airways of irritants, mucus, or foreign stuff like dust or smoke. It starts when something tickles your throat or lungs, triggering nerves to send a signal to your brain, which then tells your chest and abdominal muscles to forcefully push air out. It's like your lungs bouncer kicking out unwanted guests. Common
So,
causes include
it's an innate response, part of the immune system, and it wants to take an irritating stimulus away.
exactly, you got it. Coughing is an innate, hardwired response tied to your immune system, designed to boot out anything irritating your airways, like mucus, dust, or even a pesky crumb. It's your body's way of saying, nope, you're not staying here, to protect your lungs and keep things clear.
Okay. And what is is coughing a reflex then?
Yep, coughing is absolutely a reflex. It's an automatic, involuntary response triggered when your airways detect an irritant like smoke, mucus, or even acid reflux. Nerves in your throat or lungs send a rapid signal to your brain, which fires back instructions to your diaphragm and chest muscles to contract and blast air out, clearing the irritant. No
So,
thinking required.
so what nerves do we have, and what receptors, and what centers?
All right, let's get into the nitty gritty of the coughing reflex. It starts with sensory nerves in your airways, mainly the vagus nerve, which has branches like the superior laryngeal and recurrent laryngeal nerves. These nerves have receptors, like rapidly adapting receptors, RARs, and C fiber receptors that detect irritants, mechanical ones like dust or chemical ones like smoke. When triggered, they send signals through the vagus nerve to the brainstem, specifically the medulla oblongata's cough center.
Oblongata.
You got it. The medulla oblongata is the key player here. It's like the control room in your brainstem that gets the signal from the vagus nerve and its receptors, like those rapidly adapting receptors and C fibers in your airways. Once it registers an irritant, the medulla oblongata fires off commands to your diaphragm and chest muscles to kickstart that explosive cough to clear the junk out. Want to dig deeper into how this all connects? Or move to something?
So how do the C fibers connect with the rest of the process? Very briefly, you could tell me.
C fibers are sensory nerve endings in your airways, super sensitive to chemical irritants like smoke or capsaicin. When they detect trouble, they send signals via the vagus nerve to the medulla oblongata's cough center.
Hmm. So, so when it comes to the receptors, we have rapid ones and slow ones. What's going on? Can you systematize it, put everything into a system? So the receptors, the afferent nerves, the efferent ones, the centers, the vagus nerve, the C fibers, the
All right, let's systematize the coughing reflex process, keeping it clear and snappy. Start with the receptors in your airways. Rapidly adapting receptors, RARs, pick up mechanical irritants like dust or mucus, while C fiber receptors detect chemical irritants like smoke or acid. These receptors are part of sensory nerve endings, mainly linked to the vagus nerve. The vagus nerve, through its branches like the superior and recurrent laryngeal nerves, acts as the afferent pathway, carrying signals from these receptors to the brainstem. In the brainstem, the medulla oblongata houses the cough center, which processes the input and decides, yup, we're coughing. From there, efferent nerves, motor branches of the vagus, phrenic, and spinal nerves, send signals to the diaphragm, intercostal muscles, and abdominal muscles. These muscles contract to produce the forceful air expulsion of the cough. So, in order, irritant hits receptors, RARs or C fibers.
So why are they called C fibers?
C fibers are called that because of their classification in nerve fiber types based on their structure and speed. They're unmyelinated, slow conducting sensory nerve fibers, part of the A, B, C system
So
from
what's the
neurophysiology.
difference between A, B, and C?
Oh, right. Let's break down A, B, and C nerve fibers, keeping it tight. These are categories of nerve fibers based on their diameter, myelination, and conduction speed. A fibers are the fastest, thickest, and myelinated, splitting into subtypes like A alpha for muscle movement and A delta, sharp pain, temperature. They zip signals at 20 to 120 meters per second. B fibers are thinner, myelinated, and slower, around 3 to 15 meters per second, mostly handling autonomic functions like heart rate. C fibers, the ones we talked about for coughing, are the slowest, unmyelinated, and thinnest, clocking in at 0.5, 2 meters per second. They carry signals for dull pain, itch, and chemical irritants, like smoke triggering a cough. The
So
naming
what
comes
in
from
the
earth.
structure makes them ideal for in this situation, the C ones?
C fibers are ideal for detecting chemical irritants in the coughing reflex because of their unique structure. They're unmyelinated, meaning they lack the fatty insulation that speeds up signal transmission in A or B fibers, making them slower but highly sensitive to diffuse, lingering stimuli like smoke, acid, or capsaicin. Their small diameter and widespread distribution in the airway mucosa let them act like a broad sensor network, picking up chemical changes across a large area. C fibers also express specific receptors like TRPV1, which are tuned to noxious chemicals and inflammation, triggering protective reflexes like coughing when activated. Their slow, sustained signaling matches the need to respond to ongoing irritants, not quick mechanical jolts that A delta fibers handle.
Okay, so when it comes to acute, so we have different kinds of cough. We have acute cough, chronic cough. When it comes to acute cough, can you talk to us a bit about non-infectious and infectious acute cough?
All right, let's dive into acute cough, which lasts less than 3 weeks, and split it into non infectious and infectious causes. Non infectious acute cough often comes from irritants or conditions not tied to germs. Think allergies, where pollen or dust triggers airway irritation, or asthma, where cold air or exercise sets off bronchospasm and coughing. Environmental factors like smoke or chemical fumes can also spark it, as can acid reflux, where stomach acid irritates the throat. Infectious acute cough, on the other hand, is caused by pathogens. Most common is viral, like from a cold or flu, where viruses inflame the airways, prompting mucus and coughing.
Hmm. What about subacute cough? How do we distinguish between it if it wasn't for just like time? Or is that the only distinction?
Subacute cough, which lasts 3 to 8 weeks, is mainly defined by its duration, but there are other factors to distinguish it from acute, under 3 weeks, or chronic, over 8 weeks, beyond just time.
Well, what are they, dude?
Oh, right. Besides duration, subacute cough stands out from acute or chronic based on its causes and how it evolves. Subacute cough often follows an initial trigger, like a viral infection, where the acute phase lingers as post infectious cough due to airway inflammation or heightened sensitivity. Unlike acute cough, which is usually tied to active infections, like a cold, or sudden irritants like smoke, subacute might involve slower resolving conditions, such as post viral bronchial hyperreactivity or early signs of something like asthma kicking in. Compared to chronic cough, which often points to ongoing issues like COPD, GERD, or tumors, subacute is less likely to signal a persistent underlying disease and more likely to self-resolve. Clinically, doctors look at recent history, like a cold 4 weeks ago, response to initial treatments, and whether symptoms are fading or persisting to pin it down.
Let's talk a bit about chronic cough too now. So, how do we distinguish between chronic cough and subacute cough? And also, I'm a bit confused in regard to um, how we decided that 3 weeks to 8 weeks is going to be subacute and that less than 3 weeks is acute. Like, where did you find these numbers?
All right, let's switch gears and dive into this cough question with a clear head. So, you're asking about the difference between chronic and subacute cough and where those timeframes like 3 weeks, 8 weeks come from. Let's break it down. A chronic cough is one that sticks around for more than 8 weeks. Subacute cough, on the other hand, lasts between 3 and 8 weeks. Anything less than 3 weeks is considered acute. These cutoffs aren't just random numbers pulled out of a hat. They're based on medical guidelines, like those from the American College of Chest Physicians and other respiratory experts. The idea is that the duration of a cough can clue doctors into what's causing it. Acute coughs are often tied to short-term issues like a cold or flu. Subacute ones might linger from something like a post-viral syndrome or early stages of a more persistent condition. Chronic coughs, though, often point to deeper issues, think asthma, GERD, or even chronic bronchitis. The 3 week and 8 week markers come from studies and clinical patterns that show how long certain conditions typically take to resolve or reveal themselves. For example, most viral infections clear up within 3 weeks, so anything beyond that raises a flag for something else. By 8 weeks, if the cough's still there, it's likely not just a lingering infection, but something more systemic
I
or
see.
complex.
That makes sense. And we have different types of chronic cough. We have iatrogenic cough and chronic refractory cough. Yeah, other types, please.
Let's get back to English and sort out these types of chronic cough. Chronic cough, as we said, lasts over 8 weeks. Now, chronic refractory cough is a specific beast. It's a persistent cough that doesn't respond to standard treatments for common causes like asthma, GERD, or postnasal drip. Think of it as the stubborn cough that just won't quit, even after you've thrown everything at it. And it's often linked to nerve hypersensitivity in the airways. Iatrogenic cough, on the other hand, is caused by medical treatments or medications. ACE inhibitors, like lisinopril, are classic culprits, triggering a dry cough in some patients as a side effect.
Yes, but why does Lacino? So explain to me why enalapril, lisinopril, prednisolone, or this pril anyway, they block bradykinin, which accumulates. Why does bradykinin accumulate anyway during a cough? What is bradykinin?
All right, let's dive into the pril drugs and bradykinin. Lisinopril, enalapril, perindopril, these are ACE inhibitors, and they can cause a dry cough in some people. Here's why. ACE inhibitors block the enzyme that normally breaks down bradykinin, a peptide in your body. Bradykinin is a signaling molecule that causes blood vessels to dilate and can trigger inflammation or irritation. When you take an ACE inhibitor, less bradykinin gets broken down, so it builds up. This accumulation can irritate the airways, especially in the lungs or throat, leading to that persistent cough. The exact reason bradykinin causes cough isn't fully nailed down, but it's thought to sensitize nerve endings in the airways, making them more reactive. Not everyone gets the cough. It's more common in certain folks, like about 5 to 20% of patients on these meds.
So
Does
what
that
about
clear?
you mentioned GERD? What is GERD? What about other things like postnasal drip, yeah, upper airway syndrome?
All right, let's tackle GERD and the others you mentioned. GERD, or gastroesophageal reflux disease, is when stomach acid frequently flows back into the esophagus, irritating it. This can cause a chronic cough because the acid can reach the throat or even the lungs, triggering irritation or reflex coughing. Postnasal drip, another common culprit, happens when mucus from the nose or sinuses drips down the back of the throat. tickling it and causing a cough. It's often linked to allergies, sinus infections, or a cold. Upper airway cough syndrome, which used to be called postnasal drip syndrome, is essentially the same deal. It's when irritation in the upper airways, like from mucus or inflammation, leads to a persistent cough. These are all major players in chronic cough, alongside things like asthma or even smoking-related issues. Each one's treated differently. GERD might need acid reducers. Postnasal drip could mean antihistamines or nasal sprays, and so on. Want me to dig deeper into any of these?
Um, I want to ask about the Pril drugs, so Ramipril and all of these. Um, what in their name makes them like hint? What's a hint in their name that makes us think, they must be ACE inhibitors?
Good question. The hint is right in the name of those drugs. Lisinopril, enalapril, ramipril, and so on. That pril suffix is the giveaway. It's a common naming convention in pharmacology for ACE inhibitors. The pril comes from early drugs in this class and is now used to signal that a medication works by inhibiting the angiotensin converting enzyme, ACE. So, when you see a drug ending in pril, it's a strong clue it's an ACE inhibitor.
Why did we
used for
choose the end Pril though in the first place?
The pril suffix for ACE inhibitors comes from the early days of naming these drugs. It's rooted in the first drug in this class, captopril, developed in the 1970s. The pril part was derived from its chemical structure and became a convenient shorthand in pharmaceutical naming conventions.
And why did the first drug get that name?
The name captopril, the first ACE inhibitor, comes from its chemical roots and development process. Captopril was designed from studying snake venom peptides that inhibited ACE, specifically from the Brazilian pit viper. The capto part likely nods to capture or capturing the enzyme, reflecting its mechanism of binding to ACE. The pril was a novel suffix created during its development by Squibb, now Bristol-Myers Squibb, to give it a distinctive name, possibly inspired by its proline-based chemical structure, a key amino acid in the
Yeah,
drug.
probably makes sense. Okay, and is chronic cough something that is more common in women or men?
Chronic cough seems to be more common in women than in men. Studies, like those from the American College of Chest Physicians, suggest women are diagnosed with chronic cough at a higher rate, potentially due to factors like higher airway sensitivity or hormonal influences on nerve responses. For example, women may be more prone to cough hypersensitivity syndrome, which can drive chronic refractory cough. That said, men can and do get chronic cough too. It's just that the prevalence leans toward women in clinical data.
All right,
Want me to-
interesting. So, how do we assess for a systematic cough?
I'm assuming you meant a systemic cough, but if you meant something else, let me know.
I said systematic, but yeah.
No worries. I'll roll with systematic and assume you mean a structured way to assess a chronic cough. To evaluate it systematically, doctors start with a detailed history, asking about duration, triggers, and symptoms like heartburn, nasal drip, or wheezing to clue in on causes like GERD, postnasal drip, or asthma. Next, they do a physical exam, checking the throat, chest, and sinuses. Basic tests, like a chest x-ray or spirometry, might follow to rule out lung issues. If the cause isn't clear, they try targeted treatments, like antihistamines for drip or inhalers for asthma, and monitor the response. If the cough persists, specialists might use tools like esophageal pH monitoring for GERD or CT scans for deeper lung problems. The key is ruling out common causes first, then digging deeper for trickier ones like chronic refractory cough. Does that cover what you're after?
Yeah,
Or
so
want more?
and so what do we do after then? So for instance, we have a follow-up assessment. We check for improvement. If there's no improvement, what do we do?
If a chronic cough doesn't improve after initial treatments, you move to the next steps. First, revisit the history and exam to catch anything missed, like new symptoms or triggers. If targeted treatments for common causes like asthma, GERD, or postnasal drip didn't work, you might escalate to specialized tests. Think esophageal pH monitoring for silent reflux, high resolution CT scans for lung issues, or bronchoscopy for rare causes like airway tumors. For tough cases like chronic refractory cough, treatments like neuromodulators, e.g., gabapentin, might be tried to calm hypersensitive airways. Referral to a cough specialist or multidisciplinary clinic is common at this point to dig into less obvious causes or tailor therapy.
So,
Persistence
what
is
about
key.
things like corticosteroids, LTRA, FENO, blood eosinophils, pulmonary function tests?
All right, let's break down how corticosteroids, LTRAs, FENO, blood eosinophils, and pulmonary function tests fit into chronic cough assessment and management. Inhaled corticosteroids, like budesonide, are often tried if asthma or eosinophilic airway inflammation is suspected, as they reduce inflammation that can drive cough. Leotrianine receptor antagonists, LTRAs, like montelukast, might be used for asthma or allergic cough triggers, especially if there's a nasal or airway allergic component. FENO, or fractional exhaled nitric oxide, is a test to measure airway inflammation, often high in eosinophilic asthma, helping confirm if steroids might work. Blood eosinophils are checked to see if there's an allergic or eosinophilic driver behind the cough. High levels might point to conditions like eosinophilic bronchitis, guiding steroid use. Pulmonary function tests, like spirometry, assess lung capacity and airflow to spot obstructive diseases like asthma or COPD that could cause cough.
And you
If
mentioned
the
things like gabapentin, pregabalin. What about them? Explain a bit more how they work. Also explain maybe promotility agents or cough control therapy.
All right, let's dive into gabapentin, pregabalin, promotility agents, and cough control therapy for chronic cough. Gabapentin and pregabalin are neuromodulators, originally used for nerve pain or seizures, but they're helpful in chronic refractory cough. They work by calming hypersensitive nerves in the airways, which can get overly reactive and trigger coughing despite no clear cause like asthma or GERD. Essentially, they dial down the brain's cough reflex sensitivity, reducing the urge to cough. Studies, like those in respiratory journals, show gabapentin can significantly cut cough frequency in tough cases, but side effects like drowsiness need monitoring. Promotility agents, like metoclopramide or erythromycin, are sometimes used when GERD is suspected to contribute to cough, especially if there's sluggish stomach emptying. They speed up digestion, reducing acid reflux that irritates the throat or airways. They're not first line, but can help in specific cases where GERD is confirmed, like via pH monitoring. Cough control therapy, often involving speech language pathologists, is a non drug approach. It teaches techniques to suppress the cough reflex, like breathing exercises, hydration strategies, or retraining how you respond to the urge to
I
cough.
see. Okay. Um, let's shift focus and talk a bit about breathlessness. Why do we feel breathless?
Breathlessness, or dyspnea, happens when your body senses it's not getting enough air, even if oxygen levels are fine. It's often a mismatch between what your lungs are doing and what your brain expects. Common causes include lung issues like asthma or COPD, which narrow airways, making it harder to move air. Heart conditions, like heart failure, can reduce blood flow, leaving tissues starved for oxygen, triggering that gasping feeling. Anxiety can also ramp up your breathing rate, making you feel short of breath without a physical block. Other culprits include anemia, where low red blood cells limit oxygen delivery, or even obesity, which puts pressure on the lungs. It's your brain's alarm system saying something's off, whether it's physical, like inflammation or obstruction, or neurological, like a heightened perception of effort.
Talk to me more about this perception.
The perception of breathlessness is fascinating. It's less about actual oxygen levels and more about how your brain interprets signals from your body. When you breathe, receptors in your lungs, chest wall, and blood vessels send info to your brain about air movement, chest expansion, and CO2 or oxygen levels. If something disrupts this, like airway obstruction, weak muscles, or even anxiety, your brain might sense a threat, amplifying the feeling of, I can't breathe. For example, in conditions like COPD, damaged lungs make breathing less efficient, so the effort feels huge, even if oxygen is okay. Anxiety can trick the brain into overreacting to normal sensations, making you hyper aware of each breath. This perception is shaped by the brainstem and cortex, where emotional and physical inputs mix. Chronic conditions can heighten this sensitivity,
And
so the
there's
brain.
and there's many diseases that might be causing breathlessness. Maybe it's pulmonary embolism, maybe it's pleural effusion, maybe it's pneumonia, asthma.
You're right. Breathlessness can stem from a wide range of conditions, and sorting them out is key. Pulmonary embolism, for instance, is a blood clot in the lung arteries,
We don't need
blocking
to go
blood.
in detail to each one of them. We've done so many podcasts on them, but I just wanted to kind of uh, mention. Um, if you wanna though, tell us how you would categorize respiratory diseases. For instance, which ones are COPD, which ones are restrictive, stuff like that. How would you systematize them?
All right, let's systematize respiratory diseases in a clear way. Respiratory diseases generally fall into a few big categories based on how they affect the lungs. First, obstructive lung diseases, where airflow is blocked or slowed, making it hard to exhale. COPD, which includes chronic bronchitis and emphysema, is the classic example, along with asthma, where airways narrow reversibly. These are marked by low airflow on spirometry, like a reduced FEV1 FVC ratio. Second, restrictive lung diseases limit lung expansion, so you can't take in enough air. Think interstitial lung diseases, like pulmonary fibrosis or pleural effusion, where fluid around the lungs restricts movement. These show reduced total lung capacity on pulmonary function tests.
So is something like asthma part of COPD or no?
Good question to clarify. Asthma and COPD are both obstructive lung diseases, but they're distinct. Asthma is typically reversible, meaning airway narrowing can improve with meds like bronchodilators or steroids, and it often starts younger, tied to allergies or triggers. COPD, which includes chronic bronchitis and emphysema, is largely irreversible, with progressive damage from smoking or long-term exposures, usually seen in older adults.
Okay,
There's a
okay.
gray area.
And why is asthma not? Is it because it's reversible that asthma is not in part of COPD? And also, what about empyema? Can you explain to us what empyema is? Oh.
Yeah, exactly. The reversibility is a big reason asthma isn't part of COPD. Asthma's airway narrowing can often be eased with bronchodilators or steroids, meaning lung function can return close to normal between attacks. COPD, on the other hand, involves permanent damage to the airways or lung tissue, so the obstruction stays, even with treatment. That's the key distinction. Asthma's more dynamic, while COPD's damage is progressive and fixed. Now, emphysema, a type of COPD, is when the tiny air sacs in the lungs, called alveoli, get destroyed. These sacs are where oxygen and CO2 swap places. In emphysema, often caused by smoking or long-term irritant exposure, the alveoli break down, forming larger, less efficient spaces. This reduces the surface area for gas exchange, making it harder to breathe and leaving you feeling short of breath. It also traps air in the lungs, which is why spirometry shows that obstructive pattern. Unlike asthma,
Okay, and Let's talk a bit about uh, about MPM a bit more. I'm a bit confused. Just two or three sentences.
I'm assuming you're referring to MIP and MEP,
No, no,
maximal inspiration.
is it not a thing? Am I making it up? MPM?
Oh, my bad. Let's clear this up. I think you're talking about MPM, likely meaning malignant pleural
MPM,
mesothelioma.
it's a thing. I just Wikipedia did. MPM, EMPYEMA.
Got it. You meant MPM as in empyema, not malignant pleural mesothelioma. My apologies for the mix-up. Empyema, often spelled EMPYEMA, is a condition where pus collects in the pleural space, the area between the lungs and chest wall, usually due to an infection like pneumonia or lung abscess. It can cause breathlessness, fever, and chest pain, and often needs drainage or antibiotics to treat.
I was reading about yeah, nice. I was going to ask you about assessment. I was reading about the book. I was reading the book Word Doctor, and he was talking about it. A, B, C, D, E: airway, breathing, circulation, disability, exposure. Can we talk a bit about how we assess breathlessness? Also, if you could briefly mention before you do that, how anemia could cause breathlessness.
All right, let's start with anemia and breathlessness, then move to assessing breathlessness using the ABCDE approach. Anemia causes breathlessness because low red blood cells, or hemoglobin, reduce the blood's oxygen carrying capacity. Your body senses tissues aren't getting enough oxygen, so you breathe faster to compensate, feeling short of breath, especially during exertion. Now, for assessing breathlessness with the ABCDE approach, which is a systematic emergency framework. Airway. Check if the airway is clear. Is the patient speaking normally, or is there stridor, wheezing, or obstruction? A blocked airway, like from swelling or foreign body, can cause breathlessness. Breathing. Observe breathing rate. Is the patient breathing too fast, too slow, or having trouble breathing? Note any use of accessory muscles, like classic inspiratory muscle use or respiratory muscle use, and observe the patient's posture. Breathing. Assess breathing rate, depth, and oxygen saturation. Listen for abnormal lung sounds, like wheezes for asthma or crackles for heart failure. Use pulse oximetry and consider arterial blood gases if severe. Circulation. Check heart rate, blood pressure, and skin perfusion. Poor circulation, like in heart failure or pulmonary embolism, can starve tissues of oxygen, worsening breathlessness.
Okay, I think all of us maybe can figure out. Okay, airway. So let's one sentence for each one. Airway.
Airway. Ensure the airway is open. Stridor or choking signals obstruction causing breathlessness. Breathing. Check respiratory rate and oxygen levels. Wheezing or crackles point to lung issues. Circulation. Monitor pulse and blood pressure.
Let's break it down. Okay, let's say in airway we something's blocking the airway. What do we do then?
If something's blocking the airway causing breathlessness, immediate action is critical. First, assess the severity. Can the patient speak, cough, or breathe at all? For a partial obstruction, encourage coughing to dislodge it. If it's a complete block or the patient is choking, perform the Heimlich maneuver, abdominal thrusts for adults or back blows and chest thrusts for infants. If that fails or the airway is swollen, like in anaphylaxis, give epinephrine if allergic, and prepare for emergency procedures like intubation or cricothyroidotomy to secure the airway. Oxygen and suction might help clear mucus or debris. Call for help early as time is critical. Want more on any specific step?
So what do we do? I didn't understand.
No problem. Let's simplify. If the airway is blocked, causing breathlessness, first check if the patient can cough or speak. If they can, let them try coughing to clear it. If not, and they're choking, do the Heimlich maneuver, fast abdominal thrusts just above the navel to pop out the blockage. If that doesn't work or the airway is swollen, like from an allergy, use an epinephrine auto-injector if available and call emergency services.
Okay.
Worst case.
Okay, let's go to B, breathing.
All right, for B, breathing in the ABCDE approach to breathlessness, you assess and manage lung function. Check the respiratory rate, oxygen saturation using a pulse oximeter, and listen for abnormal sounds like wheezing or crackles. If oxygen levels are low, give supplemental oxygen via a mask or nasal cannula. For conditions like asthma causing wheezing, use a bronchodilator like albuterol. If breathing is severely compromised, like in pneumonia or heart failure, prepare for advanced support like non-invasive ventilation or intubation. The goal is to stabilize breathing and ensure enough oxygen is getting in.
Okay, and what about, so what's the difference between airway and breathing? I don't understand.
Great question. Let's clarify the difference between airway and breathing in the ABCDE approach. Airway is about making sure the path for air to enter the lungs is open. Think of it as the pipe, throat, trachea being clear of blockages like food, swelling, or mucus. If the airway is blocked, no air gets to the lungs, causing breathlessness, and you act fast with things like Heimlich or suction. Breathing, on the other hand, is about the lungs actually doing their job, expanding, exchanging oxygen and CO2, and moving air effectively. Issues here, like asthma or pneumonia, mess with lung function, not the pipe, and you manage them with oxygen, inhalers, or ventilation. Airway is access. Breathing is the lungs' performance.
And what
Does
about
that-
circulation? So that's the next step, is like, is the vessels basically?
Yeah, exactly. Circulation in the ABCDE approach is about the blood vessels and heart making sure oxygen gets delivered.
So it's more
You
so
check-
about like the almost like order of things, like from the trachea to the lungs to the vessels.
You got it. That's a great way to think about it.
All right, tell us more about C, circulation then.
All right, let's dive into C, circulation, in the ABCDE approach for breathlessness. Circulation focuses on ensuring the heart and blood vessels are delivering oxygen-rich blood to the body. You check the pulse rate, blood pressure, and look for signs like pale or clammy skin, which could indicate poor perfusion. If circulation is compromised, like in heart failure or pulmonary embolism, where the heart can't pump effectively, or a clot blocks lung vessels, breathlessness kicks in because tissues aren't getting enough oxygen. Immediate steps might include IV fluids for low blood pressure, meds like diuretics for heart failure, or blood thinners for a clot. ECG or ultrasound can help nail the cause. The goal is to stabilize the heart and blood flow to ease the breathlessness.
And
Want
then,
more on?
so what's okay? What about D, disability?
In the ABCDE approach, D disability is about checking the patient's neurological status, as brain function can impact or be affected by breathlessness.
Well, okay, but ABC, we talked a lot about how it can impact. I wonder what's left.
Fair point. ABC covers a lot of the immediate causes of breathlessness, but D disability still has a role. In the ABCDE approach, disability checks the patient's neurological status. Think alertness, confusion, or responsiveness, using a quick tool like AVPU, alert, voice, pain, unresponsive, or Glasgow Coma Scale. Breathlessness can tie to neurology if, say, a stroke affects the brain's breathing control centers, or if severe hypoxia from earlier ABC issues causes confusion.
Okay, got it. And what about E exposure?
All right, E, exposure, in the ABCDE approach, is about fully examining the patient while preventing harm. You expose the body to look for hidden clues to breathlessness, like rashes, swelling, or injuries, while keeping them warm to avoid hypothermia. For example, a rash might point to an allergic reaction causing airway swelling, or abdominal distension could suggest a condition pressing on the lungs. It's about catching anything missed in A, B, C, or D, and ensuring no environmental factors, like trauma or toxins, are contributing. Want to loop back to any
No,
part of
no,
A?
no, that makes sense. Okay, well, we'll finish with this episode. So thanks for watching, guys, and I'll see you next time.